So good morning, everyone. My name is Monique Chaaya. I'm a professor at the Faculty of Health Sciences, and I'm the site PI for the study of LSAHA, Lebanon Study on Health and Aging. So thank you for being here. I'm really proud, my team and I, to share the insights from the Lebanon Study on Aging and Health from concept to fieldwork. So this is a collaborative effort that brought together researchers from Georgetown University, University of Michigan, University of South Carolina, American University of Beirut, and its two faculty, Faculty of Health Sciences and Faculty of Medicine, and the Center for Research on Population and Health. We're very much grateful to the NIH and NIA for supporting us. But most importantly, we recognize the Lebanese community and the participants who made the study possible. And a special thanks also goes to the multiple sclerosis lab team, HeAlth lab team, that actually helped us processing the blood sample and helped us establish a biobank for our study. And a special thanks as well for the field work and the field team that actually without their dedication and perseverance, this work wouldn't have been done. So thank all, and I want to highlight that this was done under really very challenging conditions. So this is the team. The team, actually, we worked really as a teamwork, and there was a lot of strong collaboration and a lot of support and throughout every phase of the study. And actually, I think this is what make the study where we are at now, finishing it and trying to make sense of all the data that we have collected. So today's presentation, we were going to address the background methodology, quality control and field challenges, response, sampling weight, and some advanced statistical analysis. Specifically, also, we want to talk about comparing with other cognitive measures, particularly harmonization of the cognitive measure, and we will finish by findings and next step. But I want also to note that this study, since the beginning, so we started in 2019, so we started during the uprising. And then the study actually overlapped with the pandemic, with the blast, with the severe economic deterioration, with the Gaza war, and the Israeli attack on Lebanon. So, but we made it, and we're here. So, so it gives me great pleasure to introduce the first speaker. And the first speaker is Dr. Carlos Mendes de Leon. He is the PI of LSAHA, Lebanon Study on Aging and Health. He serves as professor in the Department of Global Health in the School of Health of Georgetown University, Washington, D.C. in the U.S. His work involves the conduct of population-based epidemiologic study of older adult in low and middle-income countries. His research has a particular focus on the role of stressful conditions throughout the life course, especially those related to exposure to political violence and international labor migration, and dementia risk and other common aging-related health outcomes in later life. So join me to welcome Dr. Carlos de Leon. So Carlos, you can unmute.
I think hopefully I'm already unmuted. Is that correct?
Okay.
Can you hear me well?
Yes, you're good to go.
Great. Thank you, Monique. Thank you for this very kind introduction, and good afternoon to all of you in Beirut. I take it that most of you are. It's really a pleasure to be with you here this afternoon and to share some initial data information about our study that Monique already mentioned, LSAHA, that we commenced back in 2019. And I wanted to first talk a little bit about what motivated us to begin this new population level survey among older adults in Lebanon. And we were really motivated by the fact that there was very limited population level data on Alzheimer's disease and other and related dementias in the entire Arab region, in fact, not just in Lebanon, but in the entire Arab region. And there was clearly a need to understand what the prevalence and incidence of dementia would be in Arab countries and in Lebanon in particular. I'm not sharing with you sort of preliminary data on this, but there was some suggestion that the prevalence of dementia may actually be rather high in this region. A second motivation was that there was an urgent need to understand the role of life course related experiences in dementia risk in older Lebanese adults, with a specific focus on political instability and the economic challenges that have affected many of the older adults who live in Lebanon for a long time, for most of their lifetimes. So it would be really important to understand how these kind of experiences and exposures to instability, to violence, to occupation, and what have you, and also the economic downturns would affect their health and well-being in later life. And then finally, we felt there was an urgent need to understand the changing caregiving environment for older adults with care needs in Lebanon. In Lebanon, as in actually many communities and countries around the world, the caregiving environment for older adults was dominated by reliance on next of kin, on daughters and sons, maybe grandchildren, etc., often living in multi-generational households. And that picture is changing rapidly in Lebanon, as in many other countries. And so the question arises, who is going to provide the care that older adults often need for their health and social needs? Next slide, please. I don't know if I can do that. Thank you. So the overall study aims for this project were to, first of all, build research capacity for the conduct and analysis of population-based longitudinal survey studies in a limited resource setting. We have been collaborating together since 2019 on this study now for 6 years. The idea was that we would, develop programs that would allow researchers in Lebanon to build capacity in the conduct of these large-scale population-based survey studies. In my own experience, I must say that a lot of research capacity was already there. What we were able to add to it was, I think, fairly minimal. But hopefully, many of you in Lebanon have still benefited from participating and collaborating in this study. The second aim was to design and conduct a population-based study of Alzheimer's disease and dementias in Lebanon and other relevant age-associated conditions among adults aged 60 years and over, following the model of the health and retirement study, and I will return to that in a second. And then finally, our aim was to analyze our baseline data that, as Dr. Monique just mentioned, we have completed. I'm not quite there yet, sorry. To estimate the prevalence of ADRD and uncover its risk factors and correlates among older adults in Lebanon. We had a particular interest, as I mentioned in the background, for exposures to conflict during the life course and measures of caregiving needs and arrangements and other outcomes in this population. Yeah. So what we did, we designed a study that followed the general design of the health and retirement study, which is a very large-scale population-based study of older adults in the US. And that model has been copied, has been adopted in many other similar type large-scale survey studies of older adults around the world. And these studies are all connected with one another in what is called the HRS Around the World Network. Part of our study and other studies in other international settings have included a detailed cognitive assessment to identify people who may have cognitive impairment and who may meet criteria for dementia and Alzheimer's disease in particular. And these cognitive assessments follow what is called the Harmonized Cognitive Assessment Protocol, or HCAP, that has been used in other population surveys around the world. And overall, working together with all these other international studies, the objective is to promote the international comparisons in assessing the prevalence and incidence of ADRD and its risk factors. Our study had the following components. The main part was a respondent level interview. which included a comprehensive health and social survey with lots of measures, including anthropometric measures, physical performance test, and this HCAP cognitive test battery that I just mentioned. Altogether, this interview with the respondents requires about an hour to 2 hours to complete. Probably closer to 2 hours is more realistic here. It also included a household interview, that is an interview with a respondent from the household. It could be the respondent, could be someone else, to ask about household assets, income, and expenditures in the household. It also includes an informant level interview, that is an interview with a respondent that is identified with an informant that is identified by the respondent as someone who knows them best. The purpose of this interview is to get information on the daily functioning and cognitive functioning in particular of the respondents as another measure to assess their cognitive health. And this interview takes about 20 minutes to complete. And we finally included a blood sample component. We asked all of our participants to donate a blood sample that we used to test both routine clinical biomarkers, but also for the assaying of biomarkers of neurodegenerative disease, which is currently underway. And we also save some of the blood sample of each respondent and to establish a biobank at AUB, which we also have done. The survey instrument, very briefly, this is a long list of all the different domains of questions that we ask of our respondents. It's a lot. You know, we really asked a lot of them. They were very generous with their time, for which we are very grateful. But as you see this list here, we ask about demographics and socioeconomic variables. We ask about adverse childhood experiences, about work and occupation, retirement, battery of cognitive function test, medical history, mental test. We had a series of anthropometric measurements, such as blood pressure, weight and height, physical performance tests. Of course, we needed to ask often sensitive questions about exposure to political instability and conflict. We wanted to know about their care needs and care arrangements, social support and social networks, a neighborhood assessment. And then finally, the interview with the household respondent was to collect information on wealth and assets, food and water insecurities, and the impact of the economic crisis. Thank you. Here are sort of our general design elements. Our inclusion criteria was being of the age of 60 or older and residing in either the city of Beirut or the Zahle area in the southern Bekaa Valley. We had a multi-stage stratified random sampling design. We collected our baseline data starting on October 9 in 2023, ending in early September of last year. And here you see our final sample sizes. We had a total, we have included and assessed a total of 3,027 participants, older Lebanese adults. Our goal was 3,000, so we achieved our goal. We collected also data from 2,646 informants of these participants. We collected blood from 2,409 participants, and we were able to store remaining blood samples for 2,278 participants. Thank you. A quick look at our sampling design. You see here the two study areas, one in the Zahle area and then in the city of Beirut. We basically, within each of these two strata, these two areas, we did a stratified random sampling design selection of grids. Grids are basically small neighborhood units of, I think it is 100 meter by 100 meter size approximately, that were randomly selected from the grayer areas, or from the, from the red areas that are the most populated areas in each of these areas. And then the orange dots that may be a little bit hard to see are the selected grids in these areas that were targeted. And thank you. With that, I gladly hand it over to Aya to talk about field issues and data quality control. Thank you.
Okay, thank you, Carlos. So we move to Aya. Aya is the field coordinator of LSAHA, and she supports tasks related to fieldwork implementation, sampling weights, data monitoring and cleaning. She's currently involved in post-data collection activities, including data analysis and dissemination. Aya is a graduate of nutrition at AUB and currently doing her MS in London School of Hygiene, where she currently is doing one capacity building activity. And she's been amazing. Actually, all the research team has been amazing. And what else on Aya? Aya, with a lot of initiative and looking, the floor is yours, Aya. Go ahead.
Thank you. Just trying to see if I could, yeah, I can change the slides. So today I'll be presenting the quality control protocols and the challenges we face during the data collection in the field. So I'm just gonna summarize them and try to be as quick as possible. I don't think I have control in navigating the slides. So, okay. So just quickly about the training of the data collectors. So we had a very comprehensive 8-day training with around 50 field workers and supervisors in each area. So that's 50 in Beirut and 50 in Zahle. And it was led by researchers, including a cognitive battery expert and a geriatric doctor who helped identify and help us identify and mitigate adverse events during data collection. And the key components of this training was a section-by-section review of the questionnaire. But it was very important that we did a lot of mock interviews that simulated diverse scenarios and included, for example, real-life events and real-life interactions with participants. For example, if a participant was aggressive, participant was overly talkative or distracted. And we really aimed and prioritized to identify and address errors early. So we identified common mistakes while doing these trainings and during spot checks and while listening to recorded interviews. And then we did a 2-hour retraining of these data collectors to address the errors identified during the field checks and during the simulations. And the outcome really was mainly to reduce data entry errors and improve the administration of the questionnaire. So I don't know if, okay, so we have 3 main challenges, and this is the first one, and the title of this challenge is the anxiety, mistrust, and reluctance to participate. So security concerns in high crime areas made participants hesitant to engage, fearing theft or kidnapping in some situations. And the most recent Gaza war on October 7, 2023 intensified safety fears as our data collection started just 2 days later, so on October 9th, 2023. And data collectors were sometimes reported to and questioned by security forces in the area, especially in sensitive areas, and non-local team members faced greater risks of being reported. And now to mitigate this challenge specifically, go back. Yes, to mitigate this challenge specifically, we tried our best to increase visibility and public outreach, and this was done and made possible through TV appearances, radio interviews, newspaper interviews that was done by Dr. Monique Chaaya and Dr. Martine Elbejjani to truly explain the study objectives and familiarize the people about the study through interviews. And data collectors also wore branded vests and lanyards, which had the logo of the LSAHA and AUB at the front, as you can see in this picture here, with one of our data collectors that was distributing flyers to a passersby. And we also tried to plaster flyers in frequented areas and public spaces, including the pharmacy, the store, churches and mosques, and in buildings where we were allowed to do so, and to passersby, just so that we could really familiarize people with the study through word of mouth. And we did closely coordinate with local authorities. So we tried to seek out approval from municipalities and mayors and ministries, inform the local police and army officials. And there's a special thanks to General Ghraib, who is the Chief of Protection and Security at AUB, who really facilitated these efforts. And the other challenge is the restricted access to certain areas. So there are certain high socioeconomic status areas that have gated communities with heightened privacy concerns. And in these areas, incentives that we distributed at the end of the study, incentives were deemed insufficient. So people weren't really excited to partake in the study or be part of the study. And these buildings would also refuse that we plaster flyers on their buildings for aesthetic reasons, and which conflicted with IRB requirements. Another issue was barriers due to sectarianism and sectarian sensitivities, where some communities were reluctant to engage with outsiders, so they wouldn't let people in their community. So what we tried to do and to mitigate this, and it was a bit challenging, it was to really identify gated communities 3 weeks in advance. So we would send out the field to work in the area 3 weeks in advance, distribute certified letters to the head of building committees, and these certified letters were signed and written by Dr. Monique Chaaya, and it also had her contact information so people could reach out either through email or by phone, just really for verification purposes. And we also tried our best to recruit local data collectors to leverage community familiarity and build trust whenever it was possible. Another issue was the gender dynamics, which affected the distribution of the sample in a way. So women sometimes would require approval from the male head of the household, and they were reluctant to engage with strangers if a male figure wasn't present in the house. And oftentimes males were not available. So they were not available during working hours, which was when we were trying to approach them. So men were less accessible. So this meant that our sample would be skewed towards having a more female represented sample. So it was more skewed towards women. And in order to mitigate this, we adjusted our data collection schedule. So the first visit would be during working hours, the second visit would be after working hours, and the third visit would be on the weekends. However, this meant that the timeline of data collection would be extended, and data collectors had other commitments, which meant that we had high turnover of data collectors, which also meant that we needed to add additional cycles of training. So it was a bit hectic in a way. As for data monitoring, also I'm trying to summarize this as quickly as possible. So it was much more rigorous than a one-slide presentation. But we did have daily reviews of the interviews initially, but then this later shifted to weekly review of the interviews in the forms. And we also collected recordings of the interviews whenever the participant consented, and we reviewed randomly around 5 to 10% of the interviews. And we went over and identified issues that are in this list here. And whenever we had an extreme value, we went back to it and we made corrections directly when possible. As for the data cleaning, I'm going to focus my attention only on the cognitive measures at this point here. Since we will go we'll talk about this in greater detail in a bit, but we're part of the HCAP network, so we followed HCAP strategies. And they said don't know responses to 0 and refuse to missing, and for the cognitive measures, of course. And after that, we examined them patterns of missing data, and we did more in-depth investigations of unlikely response patterns. And again, we try to use as much of the recordings as possible if it was available. So we would go back to the recording if we identified any discrepancies. And for when we had hard copies, we would use that and compare it to the data entry just to make sure everything is consistent and works well. As for the missingness that we had at the end of the cognitive module, we tried to we're working on pursuing imputation methods for missing data, and this is made possible by our internal biostatistician, which is Dr. Khalil Asmar, and also we have plans to collaborate with the Gateway to Global Aging team. That's it. Thank you so much for your attention.
Thank you, Aya. Thank you for joining. Dr. Martine Elbejjani. Dr. Martine Elbejjani is an assistant professor and neuroepidemiologist at the Clinical Research Institute at the Faculty of Medicine, with a joint affiliation appointment at FHS with the Department of Epidemiology and Population Health. Her research focuses on examining the predictors and interplay of cognitive, mental health, and brain aging-related changes and disorder. Her work also includes building research capacity and infrastructure for aging and health research in Lebanon and the region. And she is our cognitive measure person who's actually on top of all these sides, and it's a lot of work on her. Thank you, Martine. You want this or this one?
Hi, everyone. It's really a pleasure to be here, and actually really a pleasure to see how far we've come despite the many challenges. So, you know, the core mission of this project is to improve assessments of cognitive outcomes and dementia in Lebanon. And we've built our approach around emerging trends that we're calling for more diversified assessments. So instead of doing one cognitive scale, to actually try to do a comprehensive battery of cognitive assessment, including different assessments of what we call domains. So let's say when we think about cognition, it will involve looking at our memory, at our attention, at our language comprehension, how we integrate information. And more there were emerging trends into diversifying assessments to capture this whole spectrum, and also to diversifying populations, because with cultural differences, language differences, and sometimes population-specific risk, it could be more, it could enhance our understanding of cognitive function. These efforts have been really expanded and made extremely more interesting with the rise of something called the Harmonized Cognitive Assessment Protocol Network, the HCAP network, which, building on accumulated evidence since 2019, they have been formalizing the effort and the support to improve assessments of cognitive health in different populations, and also doing cross-cultural examinations and more harmonized ways into how we can assess mental health. So when we're starting to build our own cognitive battery, we faced a challenge that other settings do not have to face, which is the very limited information and availability of validated cognitive scales. So we actually, in the first column, we see the combination of items typically included in the HCAP battery, whereas in Lebanon, in our setting, we were only guided by the work of Monique on the pilot, integrating the 1066, a battery of cognitive function. So we had to first start our journey with doing a lot of digging, looking for scales, looking for available scales, adapted, translated, validated in Lebanon. And this is the work of PhD student Maysan Kabalan. We did a very extensive systematic review, reviewing all available studies. I will just point you to, this little dot here, which shows you how many times a study has been validated across populations and the psychometric properties identified. And so you can see that we are in a setting where we do not have a scale that has been replicated in more than one setting. We do not have a scale that has been replicated importantly for cognitive function. Most of them were for hard outcomes like dementia, which is, easier to screen than capturing cognitive function. So following this very, very large research in available data and scales, we started to build our own battery with what's available. So first of all, we mapped available batteries to the domains covered with the HCAP. So we found that we have a good, good mapping on orientation, good mapping for memory assessments, good mapping for language, and a good mapping for visual scales. What we were lacking were scales on executive function, which is, how we process information and make them into tasks. All right. So again, implementing a search of what's available, we compiled tests. We added tests to the 1066 and already available items to look at delayed memory, executive function through 3 combined tests, and more on language and fluency. Now, after selecting these tests, we had to also do some round of adaptation and implementation, and there were challenges and decisions. We were guided by, clinical insight, by the wonderful work of Alexa that helped us select, letters and fluency tests that can be mirrored between languages. And in the training, throughout data monitoring, we had to also pay attention to contextual factors in our setting. So our setting ranges from having low literacy to high multilingualism. So we had to, make sure that both are well monitored and covered. And we had to make, lessons learned from the field. So for instance, some questions and items, like, an example is what's common between a watch and a ruler. And that item didn't perform well in Lebanon because in English, it would translate, what's common between a watch and a ruler, and the concept of measuring is there. But in Lebanon, when you say what's common between ساعة ومسطرة, people don't think of ساعة as عم بتقيس شيء. ساعة بتاعت الوقت. So people, even high-educated people were not, were saying they have numbers, they have kaza. Anyway, and also, we struggled a lot with what we call historical political context. So we had to change because we had a president and then we didn't have because one of the questions is name the president. It's about orientation. So we had a president, we didn't have a president. And then the previous president became a delayed memory, not a current memory test. So, other historical context that, we had to pay attention to. I just want to say that this ended up with us having really good coverage of the HCAP battery, and also interesting comparisons with other studies that have worked more on including executive function and more assessments of language, whereas older batteries focus more on memory. And I will pass back the mic to Carlos.
Here we go. Thank you. I will continue. Thank you, Martine, for that overview of the development of our cognitive test battery in LSAHA. I wanted to share some data with you, some initial data. First of all, what was the response rate? Given our stratified random sampling design, we were really curious to see what the overall response rate would be. As you see, the overall response rate was 69%. We are very pleased with that. That's actually a very good number in the context of population level surveys internationally. I think we can be very proud of that. This is, by the way, a very rigorously computed response rate that includes households that we were not able to contact and everything. So again, we are very pleased with that. You also see that the response rate in Zagreb was somewhat higher than in the city of Beirut. That's not unexpected. That often happens in urban areas that are more difficult to reach respondents. Thank you. Then a quick note on sampling weights. As you see in these two columns here for the raw percentages and the weighted percentages, I already mentioned that we had some trouble recruiting male participants in our study. They were often not available during the day. They were not in the households during the day. We did our best, but still ended up with only 37.1% in our sample, which we knew was an underrepresentation of what they are in the overall population. So when we used some Lebanese data, there's not a lot of Lebanese data on the composition of the population in Lebanon, and specifically in the 60 year and over age group. But we found some data, and so we used that data to calculate weights, and so therefore we see that if we use the weighted percentage, now they represent 47%, 46.9% instead of the 37.1%, which is probably a lot closer to what their proportion is in the actual population. For age categories, we did a little bit better in the sense that the numbers we got, the percentages we got in each of these four age groups were closer to the actual population estimates. We had a little bit of an oversampling of younger old adults in the age group 60 to 90, and a little bit of an underrepresentation in the two oldest age groups, the age groups 80 to 89 and 90 plus, so that after weighting, they would be upweighted somewhat, as you see in the last column. Thank you. And then I wanted to speak briefly, and building on what Martine just mentioned about our cognitive test battery and how it is aligned with the way cognitive functioning is measured in all these other international surveys. We started to work on the quantitative structure, if you will, of our cognitive measures through the use of a confirmatory factor analysis. And the purpose of this CFA, confirmatory factor analysis, is to eventually create an overall global cognitive score. CFA is guided by certain goodness of fit criteria that you see listed here. And the targets for a confirmatory factor analysis is a RMSEA of less than 0.05, comparative fit index of greater than 0.95, and an SRMIR of less than 0.08. Those are the criteria. We succeeded in the first with the RMSEA and the CFI in our initial confirmatory factor analysis of all of our cognitive items. However, the SRMR in the initial model, at least, was a little bit higher than it should be. But we've continued to work on it, and I'm happy to report that I think we are very close to a final model that actually fits all of these goodness of fit criteria. And you see what kind of data explorations we did to try to improve the model fit. And our ultimate goal is to identify the cleanest, most justified data structure of our cognitive data so that we can implement that to come up with yeah, you can move on, please. Next slide. Overall cognitive performance score that you see here. This is a pictorial representation of a confirmatory factor analysis. On the right side, what you see is all the individual cognitive test items, not the scales, but each individual item. Each of these items is expected theoretically to load on each of these 5 domains. Martine already mentioned them: visuospatial abilities, orientation, executive functioning, a verbal fluency or language domain, and a memory domain. And then in turn, all of these 5 domains, oops, I'm not here quite, they are supposed to load on this overall general cognitive performance domain that assembles basically the information, the data from all of the 5 individual domains. We are very close to achieving that. Once you have this model, now you can use this factor analysis model to compute each of the 5 domain scores and the overall general cognitive performance score, which we are about to complete now. So thank you, and I believe it's up to Dr. Monique now.
Okay, so now we move into the findings and next steps. So I'll be talking a little bit about who is in the sample, about some key health indicators, non-communicable diseases, mental health, cognitive, social well-being, and later on what are the next steps. So we talked already about the sample. The age group is between 60 and late 90s, and on average we had 70 years of age of our sample. And as mentioned before, that the sample comprises of a high proportion of female, but this will be corrected when we do the weighted analysis. And the sample also reflects some kind of a good proportion of people who did not complete primary education, another 1/3 who did intermediate and secondary level, and a small proportion who have higher education, a much higher proportion in Beirut who have completed university compared to Zahle, which is 8 compared to 21%. So I think this is something that may be of interest to most of the people who are here today. So what's the key? Some of the key indicators all are descriptive. So we have almost 1/3 who were diagnosed with diabetes, but I'd like to point out that out of those whose doctor said that they have diabetes, 79% have uncontrolled diabetes based on the biomarker analysis with HbA1c greater than 7. And this is actually worrisome. And the same was done with hypertension. Hypertension, 58% They were diagnosed by a doctor that they have hypertension. This is more than 50% of our sample. But yet also when we took blood pressure measurement, 3 measurements during the interview, also we realized that many of them have very high blood pressure that at one point in time warranted actually the involvement of our doctor geriatrician to call him and to say, what do we do with somebody who has 200/12, for instance? So actually we attended to these. We have 31 who are diagnosed with cardiovascular disease, 47 with hypercholesterolemia. I think these are really concerning numbers for our participants who are 60% and older, and 20% they reported they consider their self-rated health as poor. Moving on to mental health, so we have two tools. Both of them were validated. The general anxiety tool and the SESD, which is for depression. And again, 39% had moderate to severe depressive symptomatology. And for the depression also, we have 59% who expressed depressive symptoms. Again, expected, yes, but again, worrisome and very high. In terms of cognitive function, because as you said, a lot of work is still undergoing, so we did not report on all the batteries that Dr. Martine presented or Carlos, but I took only one measurement based on IQ code. So IQ code is the informant questionnaire on cognitive decline for the elderly. So this is the informant reporting on the elderly he or she knows for at least 10 years. And what we found out is actually like 1 in 5 or 1 in 4 have showed signs on decline based on the informant. And when we asked the subject to report on their subjective memory, 54% that they said that I have fair and poor memory. We know that it does correlate with the actual memory problem, but it's not 100%. And going into care and unmet needs, and which reflect actually their performance, their functionality. 17% reported having difficulty in performing at least one daily activity, such as showering, eating, dressing, or going to do some instrumental activities of daily life. However, again, the concerning number is that among those, only 68% had unmet need. And how we define unmet need, it means that they don't have anyone to help in any of these activities. So it depends on how they see. Maybe they don't perceive the need, but however, they said when we asked them, do you have difficulty in dressing? And they say no, and they say yes, but they didn't have anyone to help them. So again, we have to be very careful how to interpret the unmet need. Again, asking them about how the current situation affected them, 56% reported that they were unable to buy their medication. And maybe that's why some of their NCD were not controlled, because they actually, some of them reduced the intake of medication or stopped taking medication during the crisis. And 70% reported not being able to cover their basic needs. Again, this is reflect how vulnerable our elderly are. And of course, there are differences by gender, there are differences by age and by area, but these are grosso modo. However, ending up on a positive note, and although people have maybe poor health, physical, mental, and maybe cognitive, however, 78% reported that they have someone who loves them, who care for them. And I think this is extremely good, because this actually help and moderate the effect of our stressor on cognitive or on mental health. What are the next steps? I think the most important next step for us is to secure continued finding. Dr. Adib, I think your dream is to have a cohort. This is a cohort, not a national, but I think quite representative of 2 areas in Lebanon, an urban and rural. So most importantly now is to have wave 2. And because wave 2 will tell us about the cognitive decline, and we will be able to uncover some of the risk factor. We are doing, as mentioned before, in-depth analysis on imputation to impute missing data. Currently, we have 40 blood samples that went to Amsterdam to validate those blood samples, because some of them came from Zahle, and we want to make sure that those blood samples are stable and we are able to do the ADRD. So now we are after doing the biomarker for the Alzheimer's disease and related dementia, p-tau, amyloid beta, and others. And we hope that once we validate, we will ship 250 blood samples to be tested for the Alzheimer. And we will be doing a lot of community engagement and preparation for upcoming waves. So keep the community engaged with us so in order to have another high response in wave 2. And
زبدة بيض حمر بحر دسمة 10
Okay, this is our QR code. If you'd like to scan and check, we have a website and it has documentation on everything that we've done so far. And I'd like to mention that we already did a lot of the presentation, at least to the community in Zahle particularly, and to many international and regional conferences. So, and all these are available. So, and follow us, please. And we'll take questions now. And my colleague as well can also answer questions if
Hi, Suma Rifai. Thank you for your presentation. It's really amazing. Thank you for your work. And what I'm wondering is that how is this, after you do all of that, how it's going to affect our community, and how can we do it on our level as UFS? Can we do anything regarding that? And yes, I'm worried about Alzheimer. And one thing to mention, I participated in this. And the thing is that when they asked for the blood test, I refused giving it. But mind you, they didn't mention that it's going to be, going for the biobank and stuff like that. So if I knew that, I would have given my... But because just like 2 days before I had the blood test and I asked them if you need just, the CBC and stuff, I already have the results, but they didn't mention it.
Okay.
So I'm sorry about that.
It's okay. So starting from the last point, so it's the first question on the consent form is whether you consent to have your blood tested or to take blood test draw. So if they say yes, so we, yeah. Yes, yes, it's usually the second one because it has a separate consent. So do you consent to have your blood drawn? Do you consent for the drawn for biomarkers? And if you say yes, then we ask you, can we store some of the blood in the biobank? I'm sorry, but thank you for this. But I mean, this is how the consent. So they, and of course we did not. And I would like also to mention that all the interviews were recorded for quality control. And of course, after taking again consent from the participants. And then we looked at 10% of them to see what went wrong. With regard to what we do, I think, sorry. Okay, but I'm just, so Kamen, I think we are generating knowledge, and I'm sure that knowledge can be translated because, as I said, we are looking at uncovering some of the risk factor. We are looking into if these biomarkers actually, they work well, and these tools, they work well in terms of identifying people who have cognitive decline or not. There's a big ethical question about whether to tell people about it or not. But while we were doing the interview, actually, we did give some advice in terms of how to improve your cognitive health. And I think all of these were based on evidence-based, like increasing your physical fitness, the type of diet, so on and so forth. I hope at least whatever we produce in terms of scholarly output will be useful for other people. But we in the website, we will have two websites, one for participant and one for researchers. So the participant would be in simple language, in Arabic and in English as well. And we're hoping that this would be accessible to everyone.
What about the Ministry of Health?
We don't have yet, yani. We will think about it. Thank you. I'm sure there should be some public health implication, but because we're now into analyzing and making sense of the data. Thank you so much. Yes. Yes, please. Please. Yeah.
Thank you very much, Monique and colleagues. My question, and I might have missed it, please excuse me for that, but why, I can understand the selection of Beirut area, but why Zahli was selected rather than other areas? And why some of the questions went back to 40? I mean, if we take an older individual at 90, you're asking question related to memory and I think executive functioning back to 40 years. I'm taking like a cross-sectional 90. For example, the president who died. I mean, is there a reason? I'm not a mental health or related to the field. And then the other question is related to what you mentioned when you compare the data that are reported by the physicians. My understanding are that these are extracted from medical records. And then a couple of the two asterisks related to blood testing. These are the ones that you've done, which included HbA1c. What are the other biological markers? I know you've mentioned some of them for the Alzheimer, but what are the other markers? And what type of validation tests are you doing in order to test the quality of blood, of plasma/blood, in order to be able to do these biomarkers?
Okay, quickly, the last one. So the issue of the diagnosis is based on a validated question that we always use. Have you ever been diagnosed with hypertension or with diabetes by your doctor? And if yes, we have a series of questions. And for all those people who have accepted to their blood drawn, we do the biomarker analysis, LDL, HDL, CRP, thyroid, TSH, and HbA1c. Not all of them were fasting, but we reported who were fasting, who were not fasting. And then we compared those who said diabetic, but HbA1c is high. And that's, we're talking about like maybe the uncontrolled or poorly managed diabetes. Similarly for other, the second one, would you like to answer the issue? And then maybe Carlos, you can respond on the Zahli. So
yes, I wanted to.
Carlos, you're muted. Let's Martine answer on the cognitive, and then you answer on Zahli.
Okay.
Okay. Thank you.
So another. Okay, so maybe I went over this quickly, but the item about asking about historical facts is not part of executive function. But most batteries, like at the intersection of orientation and, like language, like, comprehension, most batteries include some facts, okay, like historical current facts and historical previous facts. And I gave them as an example, but we struggled also with other items to adapt. But I gave them as an example because for us, like the current one was difficult to get to. So then we said Prime Minister, and then said شو اسمه إنه بيفرغوا ما بعرف ذكروا الحكومة استقالت. So like we just had to work with the context and people. When they say, oh, this is not the current prime minister, this is actually a correct answer, but we have to train people, to standardize this. إذا بيقروا الinstruction, it should be Najib Miati at the time, and they say, oh, it's wrong. It's actually a correct answer. So just to say that these are items included in, general comprehension and orientation. You usually measure assessments of like current and historical / common knowledge things.
Hello, I'm very thankful for this session, and I have a question.
Yes, please go ahead. Okay,
I went through this study, very thankful, and it happened that they told me we are going to receive the results. And I want to ask if upon the results we can have the cure or anything to help us maintain stability in our health only. This is my question. Thank you.
So, so all the participants got the result the same day on the biomarker. I mean, really the same day with that 24 hours, but not the ADRT, because we said this is for the future we'll be doing this. But just to tell you that so far there's no cure for Alzheimer, but there are issues that can help, slow the progression of the disease. And we may not talk about now dementia or cognitive, because we don't have yet the measure for dementia, but at least it can help improving the cognitive function. As I said, there are some like physical activity, good diet, so on and so forth. Thank you for your question. But can I ask, Carlos, can you please respond on the choice for Zachley? Dr. Martine?
Yes, thank you, Monique. Can you hear me all right? Is the audio okay? Good. Yeah, that's a very good question. Why Zachley and why Zachley and Beirut in our sampling design? Ideally, we would have done some sort of random selection of areas throughout all of Lebanon, but for many reasons that was just not feasible. First of all, we didn't have the resources to do it. Secondly, there are areas in Lebanon, of course, that would be much more restricted than other areas. So they would not be eligible for being included in such a stratified sample. So what we did instead was to think of a sampling design that was both economical, feasible, and where we thought we would have a good success in achieving our goals for recruitment and the study itself. And so we decided we had to include Beirut, of course, as the major urban metropolitan center of Lebanon. And we added Zachley for two reasons. Or for several reasons. First of all, it's more of a rural area that could represent all of the rural areas in Lebanon. It has a fairly heterogeneous population in terms of the different sectors and everything. So recruiting from the Zachley area would give us some representation of all the diverse groups in Lebanon we were hoping. And thirdly, and equally importantly, we felt that we could really establish good community support for our study in Zachley and surrounding areas, which we in fact have been able to do. And so this has helped us enormously with our recruitment efforts there as well. So we had the community support, it was diverse, it was also within somewhat easy reach of AUB and the lab for the transportation of the blood samples. All of those criteria came together in selecting that area as the second area for our study. Thank you.
If I may add, and if I may add also, we did it because of the familiarity of several of the investigators to the Bekaa area, and we chose Zachley again because of the diversity, and also because of seeing some refugees, because we did not take informal settlement, but I mean, we didn't exclude anyone who is there for a long period of time who would be Syrian or refugee from Syria, but not informal. Not really outside the range of the. Okay, do you hear me, Layla?
بفتكر عم لأنه عم بفشل لأنك مثبتين.
Okay, thank you, Laila, for your question. I think recently I've seen those high percentages of depression and anxiety among older adults. I don't think it's really beyond the range, the typical range. But again, we said that we worked under difficult, and there were really all precarious conditions around that time of data collection, and not to mention we were getting out of the pandemic. There was the serious crisis where many of the retirees have already lost their income, and there is really loss of wealth. For many of them, those 60s and this, not even it was 60s and 70 have lost their wealth. And the issue of the war, because we started on October 7, and I think there was around us many stressful life events, even if people were not immediately affected, but I think they were affected. And we know in 23, 24, or 24, during Gaza, we didn't have really the full-fledged war, but we had many events, and people were like, there were many Israeli attacks on several areas, and the Bekaa and other, but where we work, it was safe enough. So I think this could explain, but definitely there should be more work on it.
Thank you, Monique. Salam has a question.
So thank you for the study. It's very interesting. Have you considered adding imaging data to the study? I mean, you have biological samples, you have clinical data, cognitive testing. The only thing missing is imaging, and I think it would be a great addition to your study.
Sure, I'll be happy to address that question. Thank you so much, and it's an excellent point. Have we considered adding imaging studies to our sample? Sure, we have thought about it. The idea has come to us for sure. I think the main reason for not having included that in our overall study is sort of a cost and a participant burden issue. Obviously, imaging studies are very expensive. And this is a population level study, as you saw, with over 3,000 participants. It takes a lot of resources to add an imaging study. Having said that, though, I would say we welcome any ideas, any thoughts of adding some sort of imaging study that would be more selective. But now that we have our baseline data, we can really start thinking about these type of projects that can be added on top of this population survey by selecting certain criteria from our participants into imaging, into an MRI study. So if anyone is interested to pursue that, then please let us know, and we are happy to work together to see if we can add a meaningful imaging study to get at the brain pathology, of course, of older adults with and without maybe cognitive impairments in this population.
Thank you. So maybe we can take just brief questions and then.
Yes, just a second, Dr. Hanoun. There are a lot of studies showing that with MR and artificial intelligence, we can predict patient with Alzheimer who can move from cognitive decline, like mild to severe. So you don't have MRI or another imaging modalities, but do you think with the sample size and the data you have on predict such results?
Monique, would you like for me, or are you? Okay.
I just want to say that, ultimately these are next steps that we are really hoping to achieve. I just want to highlight how, the road is stepwise, So first, to understand trajectories of MCI to dementia, we still don't have this knowledge in our population, actually in all Arabic-speaking population and context. So first, for instance, like now with our cognitive assessments that were, very novel and implemented, our first step is already to be able to see what constitutes such trajectory. Then I can, relate it, etc. But obviously, we are interested, we collected biomarkers data, we're planning follow-ups, thinking about integrating multiple sources of data and implementing. I just want to highlight just really how many gaps in knowledge we have in our context.
Take the last question, please. Thank you. Hello, Jamal Hathout. Short question. I just wanted to ask if there is the hear loss, because I received my result. I have already a hear loss in my ear, but it's related to dementia or Alzheimer's. This is my question. Thank you.
Carlos, would you like to answer that question?
Sure. Yes, thank you. Thank you for your question. And indeed, hearing loss is very common among older adults, as you probably all know. While we did have a question on it, we didn't do a detailed investigation of hearing ability in our sample. Again, one of the many choices we had to make, unfortunately, but that's what it was. Is hearing loss a risk factor for dementia? It is indeed recognized, or at least usually listed as a risk factor for dementia. The reasons for the link between hearing loss and dementia are not entirely clear, but there is a Lancet commission that published a paper again last year in 2024 on the life course related risk factors for dementia, and hearing loss is included in that listing. So it is recognized as a potential risk factor for dementia. That's right.
Yes, yes. Okay, so I think that concludes our session. Thank you for the speaker. I think we're good on time and everyone was good on time. Thank you, Carlos, for leading all this effort. Thank you all for those who attended, and see you soon, maybe with a new result. Thank you. Thank you, Carlos.
Thank you. Thank you all. It was a pleasure being with you. Thank you.